ladies and gentlemen, dear colleague, Assalamu alaikum wa rahmatullahi wa barakatuh. On behalf of the Saudi Society for Family and Community Medicine, I would like to welcome you here in this webinar where we are going to be together tonight in 2 hours highlighting an important topic, which is update in the prevention and the management of seasonal influenza. I'm Dr. Ashraf Amir. I'm a consultant family medicine. I'm the Chief Medical Officer of the International Medical Center in Jeddah and the Vice President of the Saudi Society for Family and Community Medicine. So before we start, ladies and gentlemen, I would like to welcome you all. And I would like to thank you for having all of you attending with us together. It's almost more than 1,000 attendees. And of course, we are going to share updates in influenza regarding the disease and the vaccinations. And as you know, influenza is far more than a seasonal infection. It remains a significant public health issues globally and locally as well in the Kingdom of Saudi Arabia. We have been privileged, ladies and gentlemen, as you know, to host the mass gathering across the biggest across the globe, in fact, which is during Al-Hajj and Umrah. Millions of pilgrims that are attending their seasonal religious feast here in the kingdom. And that's why one of the major important route of infections is this mass gathering. And of course, it is a very significant problem because of the serious complication that usually encounter with a special focus on certain vulnerable populations like elderly populations or even children's, pregnant ladies, and immune-compromised patients. And of course, we have been witnessing in the recent years an important advancement in the management and the screening, the treatment, and the prevention of many respiratory diseases. On top of it is influenza infections. So in this webinars, we are going to highlight the latest epidemiological trends in the seasonal influenza. And we are going to also highlight the update in the vaccine formulations effectiveness and putting in strategies to improve the vaccine uptake for our populations. We are honored, ladies and gentlemen, to be joined with the distinguished experts. 2 of them, they are very close friends of mine and very dear colleagues, and they have always enriched, they have a lot of activities in enriching the scientific activities with their expertise. We have Dr. Faisal Farhat, who is the Director of Community and Public Health Infection and Prevention Control Program, King Abdulaziz Medical City, Ministry of National Guard, Health Affairs in Riyadh, who's going to talk about the global and national burdens of influenza trends and surveillance. But before I welcome Dr. Faisal, I would like just to remind you for a housekeeping notes where you have to put your Q&A in the Q&A box, so we'll be able to collect these questions and forward it to the concerned speaker, as well as please make sure that you put your registrations number for the Saudi Commission for Health Specialty correctly in order to be granted the 2-hour CMEs at the end of this event. So without any further ado, I would like to welcome Dr. Faisal Farhat, and Dr. Ramana Dabbagh will be the second speaker. So Dr. Faisal Farhat, the floor is yours.
Bismillah ar-Rahman ar-Rahim. Assalamu alaikum wa rahmatullahi wa barakatuh. I would like to thank Dr. Ashraf and Dr. Abdul Hafiz and all our colleagues at the Society of Family and Community Medicine for their kind of contribution to such important educational webinars with a huge impact, as we always see, not only from the number of attendees, which is magnificent, but also from the impact of the discussion that we used to have in such important programs. And today I have the honor to discuss with you the burden of influenza in general at the global and the national level, and look for the trends and also the impact of the disease and the surveillance with some kind of emphasis, spotlight on the situation and the status that is related to our region, and especially in Saudi Arabia. And if we'd like to start, we'll go to the virus itself. And we know that influenza viruses, the type A and type B and type C, are all determined by the nucleoproteins and the other types of protein that are in the virus itself as RNA virus. But these types are further subtyped into different subtypes for A and for B. And these are determined by two important surface protein, the hemagglutinin and the neuraminidase, the HA and the NA. And from the number of the HA, there are 18 types of HA, and we know about 11 types of NA. So when we look for the matching of H and N, it's kind of a huge number of viruses that are circulating among the communities and the population in general. And this virus is really kind of a smart. The microbiologists and epidemiologists look for such kind of a change that happen as an errors that occur. But it's a way that the virus is surviving. It do lots of multiple replications. And during these several replications, there are some kind of errors or mutation that's been there. And the mutations actually occur in a shorter term, which is being defined as a genetic drift. And this is the result of the seasonal influenza. And that's why each year we have to receive a new updated influenza vaccine, because actually the virus is always changing through the drift on a yearly or annual basis. But also on the other side, that this kind of a drift or minor change that help them affect the effectiveness of the vaccine that we receive. So it's kind of a battle between us scientists, epidemiologists, to look for what are the circulating subtypes of the influenza viruses, and then try to look for the best match for the vaccines that can tackle such kind of a change that's been there. And if you look at the data that tell us that during the past 20 years, there was almost 35 kind of mutation or change happen in influenza virus. And most of these change happened or occurred in the H3, the hemagglutinin type 3. So, and also it happened in influenza B and also in the H1. So these kind of changes is continue as a part integral of the influenza virus. That's why I can say this is the most smartest organism in the whole globe. But on the other hand, the virus also do some kind of a long-term kind of change every 10 to 30 years. And this is kind of a genetic shift. It's a new virus that just evolved, and nobody has an immunity against this new virus. And that's why this is the main source for pandemics that occur throughout the years. And we experience such kind of pandemics since a long time. Maybe the earliest that we know was 1891, H3 and 8, but maybe the most devastating one was in 1918, where an estimate of 50 to 100 million deaths related to this virus, and 500 million population were infected. And this number actually represents almost 1/3 of the whole population during that time. It's a huge kind of an impact that we ever see such kind of a virus do it. Even for the COVID, although the number of cases, 700 million so far and more, being infected with COVID-19, the death was 7 million deaths. It didn't reach to this 50 million population who died because of the virus. And again, as the virus do some kind of a shift over the year, there are some kind of change and some pandemics that occur with different types that been there. Maybe the latest one related to influenza was in almost 2009 with H1N1. And this kind of a pandemic was really controlled, and the vaccine was available at that time to do some kind of an important protection and prevention. And when we count 10 years since 2009, we came 2019, and everybody in the world was waiting for a new pandemic that might be caused by influenza virus, which is avian flu. Nobody was expecting that COVID will come at the end of 2019. So, and we'll wait for the H5N1 and other avian flu that can be the source of a pandemic, which doesn't happen because of the COVID, maybe, nobody knows. But also during the pandemic, where we were all busy with the pandemic, the virus, the avian flu did some kind of an important change, where the probability of transmission came from the domestic bird into the wild bird, and from the wild bird into mammals. And recently in 2023, there was a transmission to the cattle, which is some kind of a change in the virus ability to transmit to mammals. And from the cattle to the milk of the cattle, where the concentration was high, and from the cattle to the cats. And the status was there scary a little bit at the end of 2024 because of what change will be happening. But at the moment, there is no human-to-human transmission, and that's maybe the control of things is there. But everybody was waiting for such kind of an impact. But on the other hand, if we look for the seasonal influenza itself, which is H1N1, the most circulating viruses, and H3N2, and influenza B, it caused 1 billion infection on a yearly basis. So 1 billion of the population on the whole kind of the globe are infected with influenza on an annual basis. And 3 to 5 million of them actually are severe infection that might require some kind of hospital admission or complicated cases. And look for the number of deaths. It's almost 500,000 deaths. This is annual basis. If we look for a cumulative percentage or a number of deaths with the seasonal annual death related to influenza, it might exceed all the pandemics that we observe throughout or over the years. And when the influenza viruses actually occur, it's winter. It's a winter virus, so it occurs during the winter time. But the winter season, it differs from maybe one region to the other. So if you look at the data for the seasonality of the virus in the United States and in Europe, it looks like it comes in late winter, starting to surge of cases in December and come with a peak in January, February. And when we look at our data in Saudi Arabia, for example, seasonality is a little bit earlier. So the virus or the surge of cases start in late September, come to a peak in October, November, and continue throughout till March with different types of influenza subtypes. So we see majority of the cases are influenza A viruses, whether H1N1 or H3N2, but also influenza B viruses are there and circulating throughout the year. And we should not also miss the Hajj and Umrah as a specific situation in Saudi Arabia with this huge mass gathering from almost each country throughout the globe. They come, some people for Hajj and Umrah to Mecca and Medina. And this data was in March, last March 2025. And here we can see that we do have some kind of a peak that outside the winter season, and it occurred in association with Umrah and Hajj during summertime in June, and in the earlier years before the COVID-19 was in August. It's really associated with the spread that occurred during Umrah and Hajj. And if we look at also most recent data as of today, so again, the status is there with a peak that occurred after the COVID-19. But maybe the most important point I wanted to highlight here is that we see influenza cases with different subtypes throughout the year. And this is an important, whether these are the data from the past 2 years in 2023 and 2024. And again, we see a consistent surge and increase of cases with the peak that occur in October of each year. And Hajj is really of an important concern in Saudi Arabia. And these are some data. We have several kind of scattered information related to influenza and other influenza-like illnesses and respiratory disease during the Hajj. And these are some data for returning Hajj and Umrah pilgrim, 300 Indian participants, and the positivity was 32% of them have some respiratory virus infection after they pursue Hajj and Umrah. And most of the cases, 11% was influenza related or influenza illnesses that been there associated. And also another kind of data also from Saudi Arabia, a systematic review of more than 60 papers or articles being published looked for the clinical respiratory infection and pneumonia symptoms among Hajj pilgrims. And we see how the burden among the pilgrims related to the influenza and influenza-like illnesses, including severe cases of lower respiratory tract infection and upper respiratory tract infection too. But maybe again to highlight that the coverage at this year was in 2013 was only 20% of the internal pilgrim who received influenza vaccines, which is kind of an association or relation between the coverage of influenza and the occurrence of severe infection and respiratory illnesses that been there. And for sure, COVID has did lots of changes, not only on the seasonality, which is became more earlier, and so cases we saw out of the season, but also on the severity of the cases. And some of our colleagues look for why we see more severe illnesses after the COVID, and this was related to the wane of immunity related to influenza and influenza. So there is no vaccination or reduced coverage of the influenza vaccine. And also the exposure that led to a natural infection has been also reduced with all the restriction during that time. And what change also happened in the epidemiology of influenza virus during the best maybe 2 years, that the WHO announced that there is an eradication, we can say, of the Yamagata subtype of influenza B. So we don't see any influenza B Yamagata viruses as per the WHO statement that since March 2020, no cases of influenza associated with the influenza B Yamagata viruses has been identified. And that's why the recommendation for the influenza virus kind of a shift back from the quadrivalent influenza vaccine that include influenza A, H1N1, influenza A, H3N2, influenza B, Victoria sublineages, and the Yamagata sublineage to remove the Yamagata from the vaccine component. And now we have a trivalent influenza vaccine that is universal in the next season, and also started in 2024, 2025 in many countries throughout the world. So again, beyond the number, even with the number of cases that are infected or related kind of hospitalization, related death being there globally and in many countries, including United States and Europe. But I wanted to look for that statement from the WHO again, that influenza can worsen the symptoms that related to the chronic diseases. And we are missing this. We look for influenza as just an acute illness for 1 or 2 days. But this 1 or 2 day kind of infection can worsen and affect the patients with chronic comorbidities, including majority of patients with cardiovascular illnesses and diabetes. On the other hand, we look for the productivity. So the total kind of loss to productivity that estimated 20 million days in the United States. So because of influenza, and this has been also associated with 11 billion US dollar of the total economic burden due to influenza. And we don't look for this kind of a burden. And also based on the data from Europe, we don't look for the burden of influenza on the lost years. So there are 82 disability adjusted life years has been lost from the community per 100,000 population. That is related either to the morbidity because of influenza or the mortality associated with influenza being there. So sometimes we look for just only to the direct acute illness, but we are missing all such kind of a societal, economic, and human burden of influenza viruses. And again, the two most vulnerable population are the two extremes of life, those who are less than 5 years of age, and especially those who are less than 2 years of age. And on the other side, the elderly population above 65 years of age. And as we see that the mortality per 100,000 population increase as age is increasing among the population. And beside those kind of two extreme age groups, there are other high-risk populations, especially the pregnant woman, obese population, patients with chronic respiratory illnesses and chronic cardiovascular diseases. So those patients actually are at risk for exacerbation of their kind of a condition if they are infected with influenza. And they also are at higher risk for some complications related to this infection, including neurological complications, cardiac complications, pericarditis, myocarditis because of the infection, and also respiratory illnesses, otitis media, for example, and other causes of sinusitis, bronchitis, pneumonia that might happen, and musculoskeletal disorders. All of these kind of related complications can period of infection or acute illness that can go beyond more duration, that can go for months or more, not only limited to few days, that between 2 to 3 or to 4 or maximum 7 days of acute illness. And these are really convincing data that showed some consistency an association between influenza-like illness consultation and the occurrence of myocardial death, myocardial infarction death. So the death because of myocardial infarction was associated with the surge, with the peak of influenza-like illness consultation rate, and also was consistently associated with the positivity rate in the sample. So when we get sample from the population and look for how many of these or proportion of these samples that are positive, such kind of an positivity rate is associated also with the increase in myocardial infarction death. And this can be explained by the direct effect of the influenza virus infection on the cardiac muscles, including, as I mentioned, myocarditis, pericarditis, heart failure that might be there, or the indirect impact because of the inflammatory process that this virus can do and affect also the myocardial muscles. On the other side, on the respiratory system, we can see how the influenza viral infection can do an inflammation and damage to the respiratory epithelial cells. And this can predispose to several kind of complications, including pneumonia, but also can predispose this respiratory system to a co-infection with other bacterial infection. And the most kind of an important bacteria that can co-infect the influenza pneumonia. And all of these are associated with severe complication among the population in general. And not only cardiac patients, but also diabetic patients, which represent a kind of huge proportion of our population, 20 to 30% in our estimates. But the influenza virus, because of the stress related to the disease itself, the infection, the inflammatory process that we do have in our body, can imbalance the metabolic control and also reduce the immune response to the infection, especially among those vulnerable population, and let those people more vulnerable to the infection-related complication and secondary infection because of those. And it was really interesting to look at this data from our world in data to find that Saudi Arabia and United Arab Emirates are the top in relation to the respiratory death rate from seasonal influenza among people who are 65 and above. And this rate is per 100,000 population is higher than the whole world and also higher than other countries, including United Kingdom and United States. What's going on and when we come to the young children, the status is maybe, or the story may be a little bit different because the presentation of influenza in children is different than the adult. So usually it comes with some kind of non-specific symptoms, just a fever that may be associated with GI symptoms or might be associated with some kind of other manifestation that is very difficult to relate to influenza and fine. And that's why we only diagnose 17% of influenza among children. There are 83% of influenza cases are misdiagnosed among young children. And on the other side, that 41% of influenza positive children less than 18 years old are at risk for kind of a complication that's related to the infection. So the disease burden is high and our detection is very low on one side. And again, the attack rate of influenza infection among children is different than the adult. It's double the adult. So 2 in 10 in children compared to 1 in 10 in the adults. So children acquire the infection more than the adults. And the severity of the infection in terms of hospitalization and mortality, again, is highest. And the elderly population, 65 and above, and the very young population, less than 5 years of age. And we can see this happen in the neonates and children who are less than 1 year and 1 to 4 years of age are the highest risk of complication related to the influenza cases. And again, I just mentioned, so the severity of influenza after the COVID is coming more obvious. And this is because of the waning of immunity. No natural protection that happened because of the restriction during the COVID and the uptake of influenza vaccination was reduced. And that's why that put the population more vulnerable to severe cases. And we observed this in 2024. And even in 2025, we see, or some our pediatrician and colleagues look for severity of influenza among the children is something that might be strange during this time. And again, children are different than the adult, not only on the severity or the attack rate that might be there, but also on the use of antibiotics. We know that influenza among children is associated with many other conditions, including otitis media, for example, sinusitis, pneumonia, and all of such situation, the use of antibiotics is used, or antibiotics are used in a very high kind of rate. So the use of antibiotic among children is much higher than the adult population. And children who are more than 3 years of age account for more than 70% of such kind of cases. So this is adding a more burden on the community and society and our medical services, not only in the cases, but also on the utilization of healthcare services that are there. So if we look for the 22 million cases of severe acute lower respiratory infection in children less than 5 years of age, 5% of those cases are hospitalized, and this represents almost approaching 1 million influenza virus associated acute lower respiratory illness hospitalization in those children. And 4 out of 10 influenza-related hospitalization were among children. But on the other side, most of those cases, 50% are healthy. So they don't have any underlying medical condition. And this is an important aspect to look for. Healthy children, healthy population are admitted to the hospitals because of influenza, and admission affect their health and also our kind of provision of healthcare services to those population. So children, actually, they play an important role. So they acquire the infection more. So the attack rate is higher. They have a high rate of symptoms or symptomatic. They're shedding the virus a lot, so they're spreading the virus more. And they have a poor respiratory hygiene, and this also contribute to the spread of infection among those population. And all of those kind of factors make the children are kind of an ideal primary driver of influenza transmission. And this transmission to the caregiver, and is associated for every 100 influenza infected cases, children less than 3 years of age, there are almost 200 days of work loss among the parents. And it comes to the family member where it can affect those who are involved with chronic comorbidities, and transmission to other children who can transmit to other communities. And again, the transmission to vulnerable population who may die or be hospitalized, especially those who are elderly people. So two important settings when we think for the contribution of children to the spread of influenza infection among the community, the schools, daycares, and also the household and family members who can acquire the infection. And if we look for such kind of interaction between the children, their grandparents, grandmothers, and also their kind of colleagues at the school, and you can see how such kind of a spread of infection can happen in the community, and how about if we are able to control such kind of a spread by increasing the uptake and vaccination among children. So this will definitely reduce the impact in the community. And this is what we look for, the indirect protection. So we are missing vaccinating our children with influenza. We think that vaccines, all vaccines are for kind of a children, except flu is only for adult and elderly population. So we are missing our children, and we have a very kind of a low uptake of influenza vaccination among children. And that's why we, in one strategy that in order to protect the whole community is to increase the coverage among children. And this is an important aspect to modulate the spread of influenza infection in the community through vaccinating the kids. And look for the data from the United Kingdom. There was some impact of more than 80% decrease in influenza-related general practitioner consultation among people who are 50 to 70. And this was associated with the coverage of influenza vaccination among school children. So 17.4% per 100,000 in areas with no school-based vaccination. It reduced to 9.4 per 100,000 when the vaccination for children was limited to primary school children. And when we expanded the vaccination to more kind of school age, primary and secondary school, so the reduction was more than 80%. So this is how beautiful the impact of such kind of intervention to reduce the burden of influenza with indirect impact on the community through vaccinating the kids and children. And again, if we look at the coverage of influenza vaccination among compared to the other vaccine, it's really low. It's really low. It's almost 20% compared to the coverage among the elderly population. And even in countries where there is some kind of a good coverage with influenza vaccination, still the coverage among children is lesser. In the United States, the coverage of vaccination among children within 18 years of age is lesser than the adults. Same situation in UK and many other countries. But globally, internationally, the coverage of influenza vaccination among children is only 12% compared to 28% in the adult population, which is really kind of a low aspect. And the coverage is important because we see here from the data that with 50% coverage of children, vaccination of children less than 18 years of age, there is a reduction of 4.4 million cases of influenza, 60,000 influenza-associated hospitalization, a reduction of protection or prevention of 3,500 influenza-associated deaths. And this is how the impact such intervention can be there with only 50% coverage. And again, consistent data from several studies being there looked for a coverage of 40%, 50%, almost 15 to 75%, and how this can impact the reduction over years, 10 years, 14 years, that can reach to almost 60% kind of a reduction of influenza burden in those population with just kind of a modest coverage among the children. And at the end, what we see here in the special influenza and other infectious diseases, that we only see the tip of the iceberg. We don't count for everything. We just look for the data that related to healthcare seeking behavior, the morbidity associated complication, admission, hospital mortality. But we don't measure the morbidity in the community, which is huge. And this impact actually is missing a lot in our population, reflected in work production and missing days of work loss, and also the productivity in the among those population, and many other kind of complication that might not be measured. And again, from this model, you can see that we are only again measuring a short period of time related to the acute illness. We don't look for the death that might happen after years because of some complication happen associated with influenza infection. We don't look for that. And that's why we are really underestimating the burden of influenza infection and similarly many other infectious diseases in general. So with the great statement that being consistently mentioned by big organization, the WHO, that influenza vaccine are safe and effective, we continue to mention this to our people. It's really essential to do some action to protect our communities. And by the CDC, that this is the single best way to prevent influenza is to be vaccinated each year. And for the European CDC, that seasonal influenza is a vaccine-preventable disease, and annual vaccination is the most effective way to prevent influenza. All of these kind of statements from these big organizations should let us to do some action as health care provider for the sake of our communities. And one important action is to understand the behavior or the attitude or what are the drives actually and barriers behind influenza vaccination in the communities. And these are data from a small sample in Saudi Arabia, almost 200 population. And what are the main motives and drives for their kind of an uptake of influenza was to protect themselves. And this is perception of threat. So when people perceive that they are at risk, so their kind of an action is there. So we are expecting that they do something to protect themselves. And the second came that it's recommended by physician. This is a main important drive and motive for people to do a vaccination. And when it comes to the other barriers for not being vaccinated, that they didn't receive information about influenza vaccine. And this is kind of a shame, I can say, related to our kind of all intervention that we don't educate, we don't aware our population about such kind of an important burden related to seasonal influenza infection. Also, another kind of a study or work being there to understand vaccine hesitancy and access misinformation. And most of these kind of things related to the effectiveness of the vaccine. This is one part. So do the vaccine work or not? Or maybe sometimes to the mode of administration of the vaccine. So all of such kind of barriers need to be really studied, discussed, looked for it, and look for if there's some kind of intervention and alternatives that can help us to improve the uptake among the population. And again, I focus on the study of this kind of data that it showed that when we offer the vaccine, the uptake is reached with a likelihood of 6 times more than if we didn't offer the vaccine. So I can say that it come to us on our shoulder as a healthcare provider, that the first step to reduce the burden is to offer the vaccine. And offering the vaccine include make it accessible, affordable, and we do an awareness for the community. All of these are including under offering the vaccine for our population. And the data tell us that whenever we offer the vaccine, people are more likely to take the vaccine. And this is what we are targeting at the end. So everybody has a role to do it. And it's our responsibility, healthcare providers and family, community, and all kind of people who are caring of the health of our communities. So we are not working just in silos as people who are interested with vaccination. It's responsibility for family physician, for community medicine, for preventive medicine physicians, for all kind of healthcare providers to take each encounter as an opportunity to educate and offer the vaccines for the population. And at the top of these kind of vaccines is for sure influenza, because annual influenza vaccination is the most effective way to prevent and to protect and to reduce the burden of such infection among the communities. So with this, I'd like to thank you all for your participation, and thanks for the kind invitation. And thank you.
Thank you so much, Dr. Faisal Fahad. Wonderful presentation. You have covered almost everything. It's a session by itself, Dr. Fahad. Thank you so much. You went through the global and the national burden of influenza, the trends, the very strong statements of WHO and other organizations for the safety and efficacy of the vaccines. And you highlighted also the barriers of vaccinations and the important role of all of us as a physicians and a healthcare provider to promote the uptake of vaccines in general, with a special focus on influenza vaccines. So thank you so much for this amazing presentation. And now, ladies and gentlemen, we'll go for the other part, which is another interesting part, in fact, which will be about the management of seasonal influenza and the real-world vaccine effectiveness, safety, tolerability. What is the latest data tell us? So we have here Dr. Amana Al-Dabbar. She's a consultant pediatric infectious disease and transplant infectious disease in King Abdullah Medical City here in Jeddah. She's a chairman, Department of Pediatric at King Abdullah Medical City in Jeddah, associate professor for pediatric infectious disease. We have been very privileged to have Dr. Amuna with us, and we are very sure that her session will be another important and interesting session for us, full of updates and full of her wealth of expertise in the field of pediatric infectious disease and in pediatric immunization. So without any further ado, Dr. Muna, I would like to thank you for accepting our invitations, and we are here eager to hear from you. Thank you so much, and I would like to leave the floor for you.
Allah يعطيك العافية Dr. Ashraf, and thank you very much actually for the presentation. I just want to make sure that you see my slides. Do you see my slides?
Yes, we can see it very clear.
Fantastic. Okay, so assalamu alaikum jami'an, greetings everyone. It gives me actually great pleasure to contribute today and participate today with you in that wonderful event on education about influenza vaccine. I'd like to thank Dr. Abdul Hafiz Khoja and the organizing committee for giving me the opportunity to participate with you today. ودائما نبدأ بالصلاة على سيدنا محمد وعلى آل بيته الطيبين الطاهرين. So what I'm going to talk about now is management of influenza and real-world vaccination effectiveness, safety, and tolerability, what the latest data tell us. So, of course, I'm coming here, I'm presenting after Dr. Farahat, Allah al-Afia, who gave actually an amazing presentation. He talked about everything. I'm going to try to focus a little bit more on treatment and management. So the objectives of my talk here is to summarize the influenza management guidelines, talking about treatment, post-exposure prophylaxis, and to present real-world vaccine effectiveness and safety data, and then review the 2025-2026 vaccine composition and recommendations. As Dr. Farahat mentioned earlier, so influenza A and B are the two types of influenza viruses that cause epidemic in human disease. The influenza A are categorized into subtypes using two surface antigens, which is the hemagglutinin and the neuraminidase. On the surface of their walls. And the influenza B are separated into two distinct genetics lineages, the Yamagata and the Victoria. The annual epidemics of influenza typically occurs during the fall or winter months, and 15 to 42 of preschool and school-age children become infected with influenza each year, and fatal outcomes have been reported in both chronically ill and previously healthy children as well. So if we talk about, in brief, global influenza burden, so the World Health Organization reported that around 1 billion cases are reported annually, with 3 to 5 million cases that are severe and accounting for over 600,000 deaths annually. As we said, influenza has its seasonal pattern variation that varies by regions, and most affected people are the young children, elderly, and those who have underlying comorbidities. In the Middle East, it has a seasonal pattern, and it's typically between the months of October to March. There are limited regional surveillance data, but there is increased reporting, and there is the SARI surveillance system now that's established, and it's actually improving and improving the data provision. There are challenges, however, always encountered in influenza, which include low vaccine coverage and under-reporting of cases. So this paper was very recently published back in March. It's uncovering the burden of influenza-associated illnesses across levels of severity in the Kingdom of Saudi Arabia across 3 seasons. And basically, this is data derived from the SARI network. They mentioned that the influenza-associated hospitalization rates average between 48 per thousand population, and the highest burden of those cases occurred in those who are older than 65 years of age, or those who young children up to less than 5 years. So an elderly, so the influenza accounted for around 269 cases per 100,000 population, and that's for hospitalization here. 269 per 100,000 population, and for younger children, 118 per 100,000 population. This basically from the World Health Organization, reporting 3 different seasons in Saudi Arabia, just showing you the start of the season, usually at the end of the year or around October, and starts in October and ends by March. And as you see, that the typical peak is usually around December and January of each year. So let's dig a little bit about management of influenza. So before we talk about management of influenza, we have to understand who are the groups of people who are considered at high risk for influenza complications. And why do we have to highlight on these people? Because those are the people that will end up requiring treatment of influenza. So those people include children who are less than 2 years of age, elderly over the age of 65 years, persons with chronic comorbid conditions, including chronic lung disease, cardiovascular disease, CNS disease, hepatic disorders, etc. People who are immunocompromised and receiving immunosuppressive medications, women who are pregnant or those within 2 weeks postpartum, children who are less than 19 years of age who are receiving long-term aspirin therapy, Native Americans and Alaskans, people who are morbidly obese, and residents of nursing homes. Okay, so these people are all considered at high risk for severe influenza infection, and because those people are at high risk, so we have to always consider treating them whenever they're having influenza infection. So again, so who else should receive treatment? It's anyone who is hospitalized for influenza also does require treatment for influenza. So the available medications include a variable list really of medications, but maybe oseltamivir is the most common, most known medication, anti-influenza drug that's approved for treatment of influenza. And oseltamivir typically is used for a duration of up to 5 days, and the duration of treatment can extend beyond 5 days in immunocompromised and severely sick patients. As we said, oseltamivir is approved for people who are having who are either hospitalized or people who are at risk for developing severe disease. And we have to highlight on that because treatment is not really warranted in people who are otherwise healthy at home, no underlying comorbidities. Other medications include peramivir. Peramivir is an intravenous formulation. There is zanamivir. Zanamivir is an inhalation formulation given at a single dose. And there is the baloxavir, also that is recommended for people who are 5 years or older. Again, to highlight, so oseltamivir is approved for children who are 1 year or older, 1 year and older, and it's approved for all pediatric population, and Paxlovid for those who are older than 5. So having said that, um, these are the recommended doses for all of these medications. This is for adults and pediatric, and the renal adjusted doses for all of these medications. So as we said here, as it says here, oseltamivir and zanamivir should be given for 5 days, where peramivir and Paxlovid are given as a single dose. And in hospitalized, critically ill, immunocompromised, doses can be extended beyond 5 days up to 10 days. I have to highlight that the recent report by the World Health Organization, they made a very clear statement where they provided a clear statement against the use of oseltamivir, favipiravir, and zanamivir in people who are at home, not hospitalized, and who do not have underlying medical conditions. And they have provided also conditional recommendation for the use of balaxivir, lenimivir, perimivir, and omifenivir for people, a conditional recommendation for people who are non-hospitalized and who do not have underlying medical conditions. So the statement in the World Health Organization recommendations is very clear to not treat people unless they have underlying medical conditions or if they are hospitalized. Um, Furthermore, the World Health Organization made very clear statement on the use of concomitant use of antibiotics in people with severe confirmed influenza, and the statement basically is against the use of antibiotics unless there is clear evidence that support the presence of superimposed bacterial infection. Furthermore, the World Health Organization also had provided clear statement on the use of steroids, where the recommendation was conditional against the use of steroids in those people, unless the patient was clinically very sick and with symptoms suggestive of acute respiratory distress syndrome. This is conclusion of the American and the World Health Organization recommendations. But what about the Saudi guidelines? The influenza recommendation by the MOH does recommend the use of oseltamivir. So this is the only drug that's recommended for children and for adults, and this is the drug that's recommended for people who are hospitalized, people who are at high risk for severe disease, and even for severe disease. Important to highlight also the statement of the MOH regarding the use of antibiotics. So the MOH that does state clearly that clinicians should investigate and empirically treat bacterial co-infections only if the patient had one of the followings: either that the patient is inpatient with suspected or laboratory confirmed influenza who present initially with severe disease, so either extensive pneumonia, respiratory failure, or hypotension and fever, and in patients who deteriorate after initial improvement, particularly in those treated with oseltamivir. And the third group of people is patients who fail to improve after 3 to 5 days of oseltamivir therapy. What about post-exposure prophylaxis? And what we mean here by post-exposure prophylaxis is that we provide an antiviral medications for subjects who are considered at high risk for severe disease um, soon after exposure, and ideally within the first 48 hours of exposure. So this study was published in Lancet last year. It's a systematic review and network meta-analyses that looked at 33 trials that looked at 6 different antiviral medications, including zanamivir, oseltamivir, lenimivir, paxlovid, and amantadine, together with rimantadine. And the study included in total over 19,000 individuals. So basically, what they looked at is the significance of post-exposure prophylaxis in high-risk population, and the how effective is the post-exposure prophylaxis in lowering the rate of symptomatic influenza infection. And basically, what the study suggested is that zanamivir, oseltamivir, lenimivir, and paxlovid were all associated with significantly reduced lower of symptomatic influenza infection, but this was not observed in rimantadine. So again, let's go back to the CDC. So here, this is for chemoprophylaxis. So basically, the CDC it suggested the use of either oseltamivir, zanamivir, or paxlovid for people who are exposed, who are considered high risk for severe influenza and exposed to people with influenza, confirmed influenza. And the recommendation here for prophylaxis is to give either oseltamivir, zanimivir, to be continued for 7 days after the last known exposure. Paxlovid, on the other hand, can be given as a single dose only. Again, post-exposure prophylaxis should be considered within 48 hours. If we're talking about beyond 48 hours, the utility and the use of post-exposure prophylaxis is going to be less efficient. And as I said, and the post-exposure prophylaxis to be given to people who are considered at high risk for complications. So who are those people? They have to be people who are at high risk. This is criterion number one. People who have not received the influenza vaccine for the current season, those who received the vaccine but within less than 2 weeks, and those who might not respond to vaccination because they're severely immunocompromised, and if the confirmed influenza index case had an infection confirmed to not match with the vaccine in the circulating season. Again, it's not recommended to provide post-exposure prophylaxis for healthy people exposed to influenza beyond 48 hours. And antiviral prophylaxis with oral oseltamivir or inhaled zanimivir is recommended by the CDC for control of institutional outbreaks. And the recommendation for institutional outbreaks here is that you give chemoprophylaxis with oseltamivir or zanimivir by at least 2 weeks and continue up to 1 week after the end of the institutional outbreaks. So let's talk now about real-world effectiveness data. So the influenza vaccine for the last year, for last season, 2024-2025, included the inactivated influenza vaccine, the recombinant influenza vaccine, and the live attenuated vaccine. So these are the different vaccines that were given in the US and approved by the Advisory Committee on Immunization Practices. So it's very clear that all actually guidelines, they do recommend very clearly that annual receipt of an age-appropriate influenza vaccine by all eligible people over the age of 6 months, as long as influenza virus continues to circulate locally. So everyone, should receive the vaccine. Everyone who is older than the age of 6 months should receive the vaccine, and vaccination should continue until the end of the season. So the vaccine efficacy and effectiveness depend primarily on multiple factors: on the age of the subject, and the immunocompetence of the vaccine recipient, and the degree of similarity between the virus and the vaccine, and the viruses that are circulating, and the vaccines being used in the season. These are very important factors to know how effective is the vaccine. This report was published by the CDC. It's an interim estimate of 2024-2025 seasonal vaccination for 4 different networks in the United States. And the summary of the report, basically, they found that the effectiveness of last season's vaccine for medically attended cases as outpatient was variable between children and adults. So for children, it varied between 32 to 60% effectiveness, whereas in adults, it varied between 36 to 54% effectiveness. And when we talk about effectiveness for prevention of hospitalization, the data suggests that in pediatric population, the effectiveness was as between 63 to 78%, and this was a bit lower in adults, ranging between 41 to 55%. This report was very recently published regarding real-world effectiveness data and prevention of influenza-like illness in children. This report was published from, the study was done in Italy. It included over 65,000 and 65,000 children enrolled in the year 2022 to 2023, and 72,000 children enrolled between the year and the season of 2023-2024. Vaccine rate here were reported in children only 12.7% 12.7 per thousand months. So let's look at the effectiveness for the year 2023. The effectiveness of the live attenuated vaccine was around 38%, and for the inactive influenza vaccine was 49%. For the year of 2023 to 2024, the effectiveness for the live attenuated vaccine was around 40%, and for the inactive influenza vaccine was around 58%. And they showed that they indicated that the overall effectiveness for the both years for the live attenuated vaccine was around 43%, and the overall effectiveness for the 2 years of the inactive vaccine was about 54%. It's true that these numbers are low, but let's look at the other perspective of giving the vaccine. Now we're talking about effectiveness of the vaccine and preventing influenza and causing hazard. So as you can see, providing the vaccine is significantly associated with lower hazard ratio, which tells you that it's protecting from the infection, and thus the hazard and the complications associated with the infection actually are reduced as well. So this is just to summarize. So the effectiveness of the vaccine as of last year was for pediatric population was around 60 to 70%, and for the adults it was around 55%, and for elderly also in the range of 55%. So what about safety profile? So as you can see here, for population for the pediatric population, the most reported safety profile showed that the side effects were very mild, and they're common adverse events, but they're very mild. And those that are mostly reported were more of a bit fever and maybe local site reactions. The efficacy for adults was excellent, with side effects were reported very rare. And for younger children who are less than 5, it was comparable between the live attenuated and the inactive vaccine, and they were also very trivial. And when we talk about the high-risk group who are given higher doses, so again, the safety trials suggest safety of the vaccine. So tolerability and safety profile for the different vaccines. So for the inactivated vaccine, it was used for over 50 years. It was reported to be safe in all age groups over the 5 months. Common side effects include local site reaction and maybe some mild fever and fatigue. And rare events reported include Guillain-Barré. For the live attenuated vaccine, they say it's safe in healthy children over the age of 2 years and for adults less than 5. And however, the live attenuated vaccine, just like all other live attenuated vaccines, should be avoided in immunocompromised subjects and in pregnant ladies. And the enhanced vaccines, it's better, which with higher doses was associated with better protection in older adults, and it was well tolerated in trials. So as of Rajab of this year, the Ministry of Health reported decrease in seasonal influenza deaths this season with enhanced vaccination effort. And they reported that there is 70% reduction in cumulative deaths compared to the same period last year. And this was mainly due to enhanced vaccination efforts. And this is a thing that deserves an applause for all healthcare providers. So let's talk about the recommendations for 2025. 2026. So the FDA had very recently released that for the coming season, the vaccine will include trivalent vaccines, including 2 influenza A subtypes for H1N1 and H3N2, and 1 influenza type B virus strains. Were selected, and the vaccines were selected based on egg-based and cell or recombinant-based. And these are the trivalent formulations that are selected for the coming season. This is trivalent formulation of egg-based influenza, included the A. Victoria virus and the A. Croatia virus, and for the B, the Austria lineage. A Victoria lineage. The other trivalent formulation of a cell or recombinant-based influenza vaccine include the A Wisconsin, the A District of Columbia, and the B Austria Victoria lineage as well. So what about the flu vaccine recommendations in children? So the advisory committee immunization practices for this coming season is not out. Usually it's released in around August, but really pretty much the recommendations are pretty much similar across the years. So I'm going to share with you last year's recommendations. So basically the recommendation is that the flu vaccine should be given to all children who are above the age of 6 through the age of 8. They should receive 2 doses if this is the first season for them to receive the vaccine. So in the first season, they should receive 2 doses 4 weeks apart, and the seasons after, they can receive only 1 dose of the vaccine. And this is basically a diagram that just shows you how to give. So did the child receive 2 doses of the trivalent, quadrivalent vaccine more than 4 weeks apart before that's for last year, so July 2024. So if the 2 doses were given, then the coming seasons, we should give only 1 dose of the vaccine. And if the child did not receive 2 doses in his first season, then he should receive 2 doses of vaccine 4 weeks apart. This statement was published in 2015, but to me, I think that this is a very important statement to highlight to everyone. So basically, this says to avoid missed opportunities for vaccination, providers should offer vaccination to unvaccinated persons older than 6 months of age during routine healthcare visits and hospitalizations when vaccine is available. And this is a very important statement that we have to advise all healthcare providers that whenever we are in the season, you have an opportunity of having a child in your clinic, just take the opportunity and give the influenza vaccine. And this is basically, I'm just quoting and I'm just echoing what Dr. Farhad just mentioned in his last presentation. In adults and children older than 9 years of age should receive only 1 dose of vaccine, and those elderly who are above the age of 65 should receive the higher dose adjuvant influenza vaccine, and this can be given in any of the formulations, whether high dose inactivated influenza vaccine, recombinant influenza vaccine, or adjuvant inactivated influenza vaccine. So in summary, annual influenza vaccination is recommended for all people 6 months of age and older. The influenza burden remains high. Prevention, early identification, and treatment are critical, especially in high-risk group, and vaccination is safe, well tolerated, and moderately effective in real-world data. And we have to encourage institutional vaccination programs in hospitals, healthcare centers, schools in Saudi Arabia, and of course during Hajj missions. So again, remember that everyone should protect herself, your family, and the community by getting the influenza vaccine. This is the end of my talk. Thank you very much.
Thank you so much, Dr. Ramana, for this wonderful, elegant presentation. You have complemented the first presentation, and it went in so much harmony that the 2 presentation was excellent completions of the whole topic. So thank you so much. And now we will start the Q&A. I have received some of the questions from the audience. The first question for Dr. Farhad. When we should start the vaccination during the season, knowing that here we have multiple peaks and multiple seasons in the kingdom. So do you have certain specifications for the appropriate timing for vaccination, especially for population at risk?
Yeah, thank you so much, Dr. Ashraf, for this important question. So the ideal timing for seasonal influenza vaccination on annual basis is before the start of the winter time. So usually it's late September in our region as a Northern Hemisphere in Saudi Arabia. So late September and early October. So this is to give protection before the winter time. And it should continue throughout the winter time, but which usually by end of March. But we should not stop vaccination for the population as long as a non-expired vaccine is still available. So the best timing is before the winter, which is September, either late or mid-September and 1st of October. And but again, we should not stop. Whenever a patient comes at risk, he should be vaccinated as long as the vaccines are still available and not expired.
Okay, thank you. Dr. Muna, we have witnessed that there is the influenza become more severe after the COVID pandemic. Is it true with the other respiratory disease? Is it the same, according to your experience as a pediatrician?
Well, I'll tell you just my personal experience. So we have noticed actually this season many cases of human metapneumovirus. So yes, I mean we've seen a lot of cases of human metapneumo who end up being ventilated and critical care. So the relationship, whether it's related to COVID, so maybe, but actually many of the infants are very young, so they're really far away from the COVID time back in 2020. What's the reason behind that? I mean, this is a thing that's very well known for viruses, is that they mutate and they change from season to season. It could be related to COVID, could be related to vaccines, and I mean, not vaccine COVID, but I mean it could be due to variability in seasons. But yeah, we have noticed metapneumovirus indeed,
Okay.
and even RSV.
Yes. Okay. In the continuation of the same question, Dr. Farhat, you have mentioned in your presentation that the death of influenza was high in the Kingdom and in United Arab Emirates in comparison to the other parts of the world. Knowing that certain populations in the other parts of the world, they are more elderly, they are more they are more immune compromised in terms of the age, while we are here still young populations in the Kingdom, but still we have a lot of comorbidities like chronic disease and others. So how do you correlate this kind of data to highlight the higher death in Saudi?
Yeah, another interesting question too. Actually, this data from to our world in data, it's kind of alerting to us, and several factors can play together to come to such kind of a burden that we see with increasing death related to influenza among our population, Saudi Arabia and United Arab Emirates, including, as you mentioned, that the increasing comorbidities in the population, for example, and maybe the uptake of vaccination is not sufficient, but also might be related to other countries where data are not sufficient. And maybe so the reporting or documentation of other cases in other parts of the world may be there. But when we compare, for example, Saudi Arabia and United Arab Emirates with other average data from the world and from the United Kingdom and from the United States, where the data are most probably are accurate there. So there is something that we need to go in depth more to analyze and to see what are the key factors behind such kind of an outcome being there. So I think more verification of the data and more kind of in-depth analysis of what's going on in situation based on an evidence within the community itself and also within healthcare. So it's really essential to look for the main factors. So that I believe several factors can be around, but first look is the comorbidity in association with the coverage, with the protection. So with low protection and comorbidities, so maybe the risk is higher, and this can come or end up with such kind of an outcome.
Yeah, thank you so much, Dr. Faisal. Dr. Muna, you have highlighted, both of you, that the influenza in children's, superimpose the complications and the high mortality in adults. So could be that a strategy that we focus on pediatrics vaccination for influenza, knowing that, as you said, Dr. Faisal, the understanding that influenza is a vaccination for adults, but not for children's. And while the infections with children's drive the major driving force for the spread of the infections across the different spectrum of age. So do you think this is a strategy, or you would like to highlight it in terms of reinforcing the influenza vaccinations for kids and children's?
So do you mean, if I understood you correctly, so you mean that we use the strategy of immunizing children in order to protect adults?
Yes.
Um, um, so there are gaps that we have to understand. So the vaccine, as we said, effectiveness is not 100%. So it's a moderate effectiveness. Okay. And as Dr. Faisal shared with us the data showing us that the highly affected group are the extremes of age, right? So even if I immunize younger children, so the data that I shared with you, we're talking about 60% protection. Okay. So still there is a chance that even if immunized, that there is maybe around 40% that the child would still have symptomatic infection. And if he's symptomatic, then he's going to spread the infection. So we're not protecting the elderly enough. Okay, so but if we target both groups, maybe we're closing the gaps in a better way. But I don't think myself that immunizing children alone is going to be enough.
Okay, and where do you position the live attenuated vaccine, Dr. Mona, in comparison to inactivated one, the one we usually use?
So the good thing about the inactivated vaccine is that it's easy to administer. Okay, as I showed you, the effectiveness data is not excellent. Okay, we're talking about 40% protection, so it's not or 50 maximum, so it's not perfect. Okay, however, it's easier to administer. And when we talk about children's fear from taking intramuscular injections and so ever, I'm confident that it's going to be easier to give to children, and maybe it would be easier to provide in campaigns. However, we have to understand the limitations and the restrictions, that we should not give live attenuated vaccine to immunocompromised children, and the same applies to providing the vaccine to a child who is in contact with someone who is immunocompromised as well, because the recommendation is that if I'm giving a vaccine to someone who's in contact with an immunocompromised subject, they should not have contact for around 7 days. So still, it does have its restrictions, but it does have its utilities. But the protection, again, is not perfect.
Well said. Thank you so much, Dr. Muna. Dr. Fahad, do you think that the empowerment of the pharmacists, nurses, will improve the vaccine coverage rates as an effective way of adding different members of the medical teams, for this kind of activities? And the self-administrations, in fact, of the live attenuated vaccine. Do you think it could be a modality that we can use to enhance the coverage?
Actually, I believe I believe that we need to get vaccines out of hospitals. So if look for some kind of a healthy individual or some person at school, for example, or university or military. So all of these kind of healthy individual, why they come to a hospital, for example, and to receive a vaccine? I think we need to get vaccination out of hospitals. And utilization of nurses will be an integral part of this kind of a success, especially for the adult immunization programs. And without such intervention, that we need to empower and to advocate for it, to get nurses like in a charge of vaccination, especially for the routine immunization program. So influenza is a routine, as Dr. Mona mentioned, for everyone who's above 6 months. So everyone, but based on his age.
Yes.
So regardless of his medical conditions, so just a competent nurse who's trained in basic kind of vaccine administration and and cold chain monitoring, for sure she should be the one who provide the vaccination for patients. On the other side, that we don't utilize the pharmacist at all. So on the other aspect, so our colleagues as a pharmacist, they are well trained, well educated, and they can play a very important part in empowering and in enhancing and supporting the immunization program in the whole community. So I think vaccination with pharmacists and vaccination with nurses will be a real kind of a success in the future for the whole communities.
Yeah, and we have successful stories of the contribution of pharmacists during the pandemic of COVID-19,
Yeah.
when the vaccine was available in the pharmacy, and this was a point of care where many of the community members, they used to have their COVID-19 vaccination. So it was a good, successful contributions, in fact. Again, the same questions is asked, but in different format. We have the life attenuated vaccine and we have the inactivated vaccine. Do you think that they will stay together? Because the contraindication of the life attenuated vaccine for immune compromised and pregnant ladies. So we cannot. These two vaccines should be available to manage the different profiling of patients. Do you think this is so?
Yeah, I believe, again, in this, I mention it as it's a value of options. So this is a value of options. So whenever there are options, we need to utilize the options. And now we have several kind of vaccines with option, like influenza vaccine now has an option, standard dose injectable vaccine and high dose injectable vaccine for people elderly 65 and above, and live attenuated vaccine intranasal, may be self-administered for healthy individual 2 to 49. So all of these kind of an options, and we should appreciate and appraise that such kind of an option being there for different populations, for children, for healthy workers, for university students. So maybe a live vaccine can work with them very well. And for other population who are not kind of an eligible for the live attenuated vaccine, can be easily given an injectable vaccine. And for elderly population who may not benefit much from the standard dose, there is a high dose. So this is a beauty of having an option, and we should such kind of appreciate the availability of several options for protection.
Absolutely. طيب دكتورة منى, what is your strategy to tackle the vaccine hesitancy among your pediatric populations?
Really, my strategy is that I give time to explain. Okay, and I think this is very important. Is that I give time and I explain and I address questions and I answer them. And I don't feel that I'm obligated to rush because I have other patients that are waiting. I always care very much to explain very clearly to the parents, and if they have any questions, I don't mind answering their questions as much as they ask, really, because from my experience, I rarely, alhamdulillah rabbil alameen, fail in convincing parents to take the vaccine. Okay, I very rarely fail as long as I give them my time and I explain the benefits, the downsides, and everything. Most of the times, alhamdulillah rabbil alameen, just addressing questions, we can succeed. But I think the key here is that every healthcare provider should advocate for giving the vaccine and should be prepared to explain in full.
Okay, well said. So, Dr. Faisal, the child who was with his parents, with Dr. Amuna, and she was capable of convincing the parents to give the influenza vaccine for the kid. They came to you as an adult to take the vaccine and they refused. So what is your strategy?
Okay, so yeah,
It's very common. In
usually,
fact, I usually come, the parents, they bring the kids, to have the vaccine, but once it comes for them as an adult to take the vaccine, they are reluctant. But so we have to understand the behavior of those people and the mindset of, and understand why they are hesitant and to tackle it. So I would like to
yeah,
hear from you.
yeah, hesitancy. It's some kind of a late decision. So usually people are coming with some concern, and people who are delaying their decision to be vaccinated has a concern. And our role is two things. First, to understand the concern behind exactly. And we are different. There are many factors around psycho-behavioral, social factors, economic factors, previous experiences, misinformation. So lots of things are there. So the first thing is to understand the concern. And how to understand the concern is to listen to your patients, just to listen. And listening that you give him all your kind of an attention and emotion. So listening should end with understanding. It's not just you hear his words. You need to listen what's behind the concern exactly. And this is by this way, you know what the exact concern. And then you should respond to your patient in a very kind of a scientific, evidence-based, and use your own stories. So stories are always play to change the attitude of people. People don't understand the statistical significance, don't understand systematic reviews, don't understand p-values, but they understand stories. So use your own stories. And we have, as a physicians and healthcare provider, lots of stories around us that can convince us and let people perceive the real threat, that it's real things being there. Healthy child without any comorbidity admitted to hospital and died because of flu. This has happened. A pregnant woman, healthy there, and lost her baby and admitted to the hospital. This is there. So use your stories at that. And the third part or second part with beyond listening is to build the trust. We should not lose the connection with anybody at all, because our mission is to protect and preserve the health and maintain the health of the population. We have a mission to protect lives of people. So we should not kind of lose a connection and communication with anybody at all. So, and vaccination usually is not an emergency situation. So if he's not convinced at this session, so maybe an opportunity next time can be there. Maybe an opportunity with other healthcare providers. Let him come to you the next time. And each time you just remind and discuss. And this is an important thing, building a trust with our communities. So listening and building a trust. And this is an important part. And part of building the trust is to make your kind of vaccination as an experience. So our maintaining of our kind of clinics, hospitals. So when people come to us, they like and they are kind of interested to come to visit us, not just afraid, be away from things, just, making an experience. This is an important part in the trust with the people. So please listen, understand your population, and always keep a trust with your patients.
Yes, I truly agree with you. Trust is very important, and building a good doctor-patient relationship, based on professionalism and trust, will convince a lot of people. And having the tools of counseling those people, the proper counseling for those people who are hesitant, as well as we should be in a position to have the proper recommendation for vaccine with courage and with proven, confidence that we can advise the patients to have, or the public. So my question, Dr. Faisal, do you think that each single person has to see a doctor for vaccinations, or the standing orders will be a solution to enhance more coverage for patients and to have this precious encounter not to be missed by having the doctors busy or they are engaged seeing patients?
Standing orders has been experienced a long time ago. CDC have lots of standing orders for vaccines. If you just type on Google, for example, standing order, whatever vaccine. So there are standing order for influenza, pneumococcal, RSV, whatever COVID or whatever vaccine. So always standing orders play an important role. So you can easily utilize these, modify based on your kind of healthcare institution and regulations, and build a standing order, give a privilege to other healthcare providers who are competent and trained for vaccination to provide without a physician order. So there is no need for physician order for routine immunization program. And this is my kind of a belief all the time.
Okay, well said, Dr. Faisal. So now, final statement from each one of you, how to advise our colleagues who are attending with us to recommend influenza vaccine in their practice. So what would you like to say regarding the prevalence of influenza, the high-risk populations, the availability of safe, efficacious vaccinations, and our role as a healthcare physicians and our healthcare providers to be obliged to recommend these kind of vaccinations. So I'll just leave it for you, please.
منى.
دكتور فيصل تفضل.
دكتور منى
دكتور
first.
منى دكتور منى تفضلي.
طيب يعني my message here is that every healthcare provider plays an important role as a part in control and education about influenza vaccine. So everyone is responsible to learn first, because when I learn about influenza vaccine, I will acquire the needed knowledge that I need to use to educate patients afterwards. And we have to be advocates for influenza vaccine, and we should always offer explaining the benefits and downsides of the vaccination, side effects, basically. What are the concerns? We have to be advocates, and everyone, I think, should start with his own community. Okay, when I start with my own community, so the message is going to be around me, and then the message is going to spread. زي ما نقول احنا snowball spread, right? Every healthcare provider is a key player in education about influenza and in the control of influenza.
Thank you so much, Dr. Mona. Dr. Faisal, تفضل.
Yeah, my message is almost echoing what Dr. Mona mentioned, but as we are with the Saudi Society for Family and Community Medicine, I would like to look and focus on the responsibility of family physicians on the vaccination. Actually, family physicians are the first encounter for all the population before they go for secondary or tertiary care. So it's really their responsibility to discuss, as we ask the patient about their complaints, the symptoms, and do all vital kind of screening and stuff like this. So a must thing to always check is to look for the vaccination among your patients. Just look for the history of vaccines, what vaccines they received, what their age, and what are recommended vaccine, and start offering the vaccine to your patient. And I think the family physician can play a significant role in the whole story, because actually an integral part in family medicine is prevention, and vaccination is prevention.
Absolutely.
So vaccination is prevention, and this is your role. So I think we can work together and to enhance and to support this area. The second part for our colleagues who are maybe in other specialties other than family medicine, internal medicine, and other specialties. So take the opportunity of patient upon discharge. So when your patient just upon discharge, just put in the checklist, discharge checklist, that check for also the required vaccines for your patient based on his age or medical condition. So I think if we work together at primary care level and at tertiary care level, I think we can close the gap and do some kind of a significant impact in the protection of our communities.
Excellent, Dr. Faisal.
Thank
And
you.
I think the responsibility of recommendation for vaccination is the responsibility of every single specialty. It's not only primary care or family medicine, everyone. So every encounter with patients in the routine visit for any patients will be a good opportunity. We should avoid the missed opportunity of having these people leaving the organization without having the vaccine. So that's why we have to alert our system. We have to use our triaging with patients to highlight the vaccination status and to adapt our healthcare system, the HIS or the EMR, to identify this alert across the board and to highlight those people who are eligible to have the vaccine. And as you said, Dr. Faisal, elegantly, and you, Dr. Muna, the primary care, they have a special important role in promoting vaccine, because the most powerful tool that we have as a primary care physicians is the vaccinations. It's the prevention. It's the core value of the prevention that we can implement. And to be distinguished from other specialties, who are totally engaged in treating the disease and treating the complication of the disease, but we go one step beyond the disease to screen, to do health promotion, early detection, specific protection for our population at risk. So with this, I would like to thank you, ladies and gentlemen, and dear colleagues, for being with us for this 1.5 hours. And then on your behalf, I would like to thank our guest speakers, Dr. Ramana Dabbagh and Dr. Faisal Farhad, for their wonderful contribution and enriching our scientific gathering with a lot of their insight and expertise. Special thanks goes to AstraZeneca for giving us this wonderful opportunity to be together today. Another thanks to Texas for wonderful organization. And I cannot forget my Society of Family Medicine, Saudi Society of Family Medicine, which will bring us all the time together to have this kind of wonderful gathering. So without any further ado, I would like just to leave the floor for Dr. Fahd, if you'd like to say anything from your side. I will leave the floor for you.
No, it's hard to add on Dr. Faisal and Dr. Ramana, mashallah, tabarakallah. I just like to thank all of you for an amazing educational session that enlightened a lot of people, inshallah. And we hope to bring better health to people across Saudi, inshallah.
Thank you so much. So with this, Dr. Abdul Hafid, okay, so with this, I would like to thank you all. I wish you a good night. May Allah accept all our efforts to safeguard our community and to work for the best interests of our patients. With this, I would like to thank you again. Assalamu alaikum wa rahmatullahi wa barakatuh.